Good afternoon, everyone. This is Jim Potter. Thank you again for joining our weekly New Hampshire COVID Vaccine Alliance update meeting. Again, for those who are new to the call, our mission is to convene stakeholders in the Granite State to promote vaccine confidence, support accurate and consistent vaccine messaging, and foster coordination of the state's vaccine allocation plan. We do this by promoting buy-in to the vaccine to increase immunizations rates, most importantly, to help act as force multipliers to support the state's communication allocations plans. Third, to counter misinformation as it arises and foster use of the immunization information system. Our sponsors, next slide, please. Again, thank you very much, Harvard Pilgrim, Anthem, Dairy Medical Center, Convenient MD, WellSense Health Plans, and New Hampshire Healthy Families Health Plans. Here are some takeaways from the last week. Of course, we're moving now into phase 3 of registrations. The first, which occurred for 40 and 49-year-olds on Monday, and from all indications that went well. Tomorrow we'll start with 30 to 39-year-olds, and on Friday we'll have the 16 to 29-year-old population. There's still some questions that we have. I'm sure more information will be coming forward later this week on the 16 to 17-year-old populations, whether they require any kind of parental approval or attendance in going for their vaccines. We'll see how some of those issues play out in further guidance, but I do expect some more information, at least no later than probably the governor's press briefing on Thursday on this issue. Also, as we mentioned, there's guidance on the vaccine strategy for homebound populations through the regional public health networks. And then if you are interested in being a vaccine distribution site, practice or hospital or other entity such as a business, first there's an application you complete on the New Hampshire Vaccine Information site. Once you send that in, it'll detail to you what things you'll be required to do. If you have questions, you can go to C19 enrollment and ask your questions of them as we're moving out. I will say just a little bit of background on that, and I think they're here. My sense is after the big bolus of patients come through, and right now I've heard that the estimate is that first shots will be given to everyone who wants one, 16 years and up, by about June 5th. So I anticipate that the big bolus of patients coming through, essentially through June, that will still be predominantly a state-run or managed effort. But when we get to that point where the rates start decreasing at some of the bigger sites, I think what you're going to see is a movement from more public-based strategy to more of a private one. And we'll hope to talk about that in the coming weeks. But I do anticipate something like that happening more. So right now, we'll go in. Next slide, please. Just a couple different things here. If you'd like some brandable vaccine FAQs that we have been developed between the Medical Society and the School Nurses Association, they're available. You can take them, you can change them as you want, you can rebrand them. It becomes a tool, particularly when we start to get to more vaccine hesitant populations, something like this, and with some key stakeholders with that message is important. Next slide, please. Also wanted to give out a big shout out to Fidelity Investments that he stood up a clinic in the last week at their Merrimack campus, and they're working with the Nashville Regional Public Health Network. And so this is a important, I think, segue. If various facilities or healthcare interests are interested in getting into being a vaccination site, or possibly coming one, I think right now the action is really kind of working and collaborating with the regional public health networks at this point. And here's a great example. Hats off to Fidelity for setting this up and helping make sure that it's manned. It sounds like it's going terrific. I haven't heard the last numbers, but I think they had 7,000 at last count come through. Anyway, next slide, please. Just to recap what we last talked about, which was the immunization information system. This is the new system that the state is moving to. Next slide, please. So the important information is on Thursday, we're transferring from the old VaxNH system. That will sunset on April 1st. I don't have a specific time frame. A couple of things you have to remember that are important is that all vaccine orders will be suspended. So if you're getting your vaccine from the state, you'll need to get it in before April 1st and have a 4 to 6 week supply available. So make sure you get a little bit bigger inventory for that period. Second, you have to reconcile all your inventory by April 1st. This is important because they want to take all the data up to date as much as it can be, and then they'll migrate that to the new IIS system as we move forward. Next slide, please. The other key ingredient here is you'll have to be trained. So even if you're a current prescriber, you have to go in and there's about a 30-minute module with a test at the end. You'll have to pass that test. And you can see right there, that's the link. And just if you're not catching this as we go through, we will make this information available a little bit later this afternoon, as we did before, on the Medical Society's website. So you'll see the slide deck, the taping of this program, and some other information discussed. Next slide, please. Okay, here are 3 other weekly information sessions that I would recommend that you participate in. The Wednesday long-term care and Wednesday afternoon, the education childcare calls. These are typically done with Doctors Chan, Talbot, and Daly, and also the health provider new Thursday noon program. They all contain excellent information for each of these sectors, going quite in detail in some of the science on some of the issues coming forward in each of these sectors. Next slide, please. Okay, at when we had our webinar with the Business and Industry Association about a week and a half ago, I was quoted in the paper of calling the legal issues surrounding requiring or incentivizing vaccines a sticky quagmire. Of course, from some of my friends, I received some of these comments if I was referring to the State House or the U.S. Capitol. No, it's not that. And the other reference had to do with Glenn Quagmire, Family Guy. So since I have lawyers in the room, I'm going to say I'm neither condoning the tactics that are used at the State House or at the U.S. Capitol or the content of Family Guy. Just want to be clear on that. So we'll roll, next slide, please. We'll roll into our main program for today. And I'd like to invite Ken Bartholomew, who is the chairman of the Healthcare Law Group for Rath, Young, Pignatelli, and Bob Best, who is an attorney at Sullivan and Hollis, to give us a presentation, an overview that they've worked on together about these issues. And then I've also invited Lucy Hodder. Lucy has some new information in discussions with the AG's office. And I thought she would, as a panelist, would help kind of round out the panel. So gentlemen, I'll turn it over to you, Ken and Bob. Thank you very much for joining us. The floor is yours.
Thank you very much, Jim, and thank you for the chance to be here. And thank you to Ken, and I didn't know Lucy was going to be here, but thank you to Lucy as well for helping out with the topic. Ken and I spoke, and we've divided up the task a little bit, so I'll talk about mandatory policies, and Ken will talk about incentivized and some of the other concerns that relate to how employers approach this. Let me share my screen so that I can. Okay. So as we ask these questions about employers vaccinating them, Jim likes the sticky quagmire. I put on my slide all the answers from the magic 8-ball that we all used to have as a kid, where you shake it up and it says, I better not tell you now. Or my favorite one, my favorite answer that the 8-ball gives you is concentrate and ask again later. It's a perfect answer when you're thinking about these COVID questions, because it does seem to change from minute to minute and nobody really seems to be giving you a direct answer. But we can find a direct answer, and wouldn't it be great to have one? A little bit of history on mandatory vaccinations. It's been litigated in the United States for well over 100 years. 1905 was an occasion where it was first litigated in Massachusetts for the government to require mandatory vaccinations for the general population. And the Supreme Court upheld that. Starting in 1922, we started to see litigation surrounding whether schools could require school children to be vaccinated, and the Supreme Court upheld that. For those of us in the healthcare industry, we sort of are familiar with the idea of mandatory flu vaccinations, and that's something that the healthcare industry has been working with and working through for a long time. And for the most part in the healthcare industry, when done correctly, the courts will uphold those as well, although potentially there still can be some litigation surrounding them. When it comes to non-healthcare employers, or even the healthcare employers, you start out by tackling a handful of questions to figure out how to approach mandatory vaccination policies. The first is the vaccination job-related and a business necessity? Certainly, if the vaccination is not job-related or a business necessity, there's no reason for you to mandate it, and you wouldn't be able to do that. So you take a look at what the job functions are, where the employee works, what their environment looks like. Do they provide direct patient care? Do they come in contact with the public? Do they come in contact with other workers? Is there a heightened risk of exposure to the employee? Is there an inability to social distance? Those kinds of factors might support a discussion or an argument that a vaccination is a job-related business necessity. And for some major healthcare institutions, essentially a decision that anyone that has contact with the public fits into these categories has been upheld. So what about a vaccination in order to say, this employee is really important to me, I don't want them to get sick and be out of work because I need them, they're an essential employee? That's probably not going to be supportable as a job-related business necessity, even though it could be very important to your business not to have people out. A potential exception to that, and I think we'll have to see how the process plays out a little bit, is in schools, where some of the teacher absenteeism or quarantining could affect whether they can manage all the students in the classroom, but that's still yet to play out before us. Another factor to consider with this is about whether you have whether you can impose a vaccination mandate while you have a collective bargaining agreement in place. And there's sort of two different issues. One is what the state or federal government will permit you to do, and the other is what rights you've bargained away in a collective bargaining agreement and agreed to negotiate with your employees upon. So potentially, if there's a collective bargaining agreement that covers these terms, even if it's lawful to mandate a vaccination, you should work with your collective bargaining units and negotiate that matter as it goes forward. Another factor that comes up a lot in this is this notion that all of the vaccines that are currently available to us enter the market on an emergency use authorization. And of course, the nature of an emergency use authorization is the FDA's approach and insistence that patients are aware that they do not have to take the medication, don't have to take the vaccination. They have that choice. That's part of what's in an emergency use authorization. Of course, that's inconsistent with the idea that maybe you're allowed to mandate a vaccination. And that particular issue is resolved just by observing that the FDA's scope and influence is over the approval of medications, and other entities regulate employment situations. So EEOC guidance, state guidance, federal guidance, and other areas are really what controls for that. So the emergency use authorization, is certainly subject to people having differing opinions, but probably doesn't have any effect on employer mandates. So if the vaccine is job related and a business necessity, you could potentially require your employees to be vaccinated. But there are exceptions. Can an employee decline a vaccination for a personal reason? Just say, I'm not interested, or I don't think the vaccines were tested enough. Or, you may have an employee say, this whole COVID thing is a hoax, I'm not doing it. Those are not valid reasons that you would have to accommodate in a vaccine policy. Can an employee decline for sincerely held religious objections? The answer to that one is yes. Title II of the Civil Rights, Title VII of the Civil Rights Act does allow religious protection for sincerely held religious beliefs, and you would have to accommodate an employee who did not want to be vaccinated for sincerely held religious beliefs. How you accommodate it, we'll talk about it in a second. Can an employee decline for medical reasons, including pregnancy? Yes. Americans with Disabilities Act covers most of the medical reasons. And pregnancy is also one of those situations where it isn't clear whether the vaccination is recommended or not. And an employer would be required to accommodate employees who object to taking the vaccine for medical reasons or for pregnancy. The puzzle there is, can the employer ask about the employee's medical reasons, pregnancy, or sincerely held religious beliefs? And the answer to that is the sticky quagmire that Jim warned you about. Don't go there. Don't ask those questions. If an employee makes those representations that there's a medical or disability-related reason, or that there's sincerely held religious beliefs, accept that answer and work towards what you might approach for a reasonable accommodation for that employee. What can an employer do about an employee that isn't vaccinated? So you've got these exceptions in your policy. Can you fire the employees who won't get vaccinated? Can you banish them from the premises? Can you make them work remotely? What can you do with an employee who either refuses to comply with your policy or meets one of these exceptions that you are required to allow? Certainly an employee that doesn't meet your requirements, it refuses and doesn't fit in one of the exceptions, you can decide what to do with that employee from a employment law standpoint, whether that's some sort of termination or disciplinary or suspension or those kinds of things. If the employee's objection doesn't fit into one of the protected categories. You can restrict even the people that fit into the religious or medical exemptions from being present on the property or on the premises of the employer if the surrounding circumstances warrant it. And it probably would, because if being at work unvaccinated was a safe thing to do, it probably wouldn't fit into the idea that it's a business necessity to have the person vaccinated. You could certainly decide to remove them from customer or patient-facing areas and try to limit the exposure that they would have to other folks. Implementing barriers in the workplace, for example, the plexiglass that we seem to see all over the place, might be a way that you could accommodate someone. There may be other reasonable accommodations that you could approach. Such as working remotely, if it's possible, depending on the nature of their work. And sometimes it is, and sometimes it isn't possible to do that, but that could be a potential reasonable accommodation for someone who fits into one of those religious or medical exemptions. But it is important to approach these things thoughtfully to make sure that you're really thinking through whether the implementation of your policy is having a discriminatory effect on anyone based on their religion or their medical situation. One of the puzzles to this with figuring out mandatory vaccine policies, and when you talk about exposure to patients or exposure to the public that would potentially be aided if someone was vaccinated, they wouldn't be able to spread the virus. That particular question, science hasn't resolved, and it's believed that you could still spread the virus to other individuals even after being vaccinated. And so as you puzzle together what constitutes job-related and a business necessity, sometimes it can be a little tricky to decide that I'm doing this to protect my patients or to protect the public. And let's see, last slide, and then I'll turn it over to Ken and let him have the floor. The clear answer on whether you can have an employee mandate. Yes, you can, if the need for vaccination is job related and a business necessity, if there are exceptions to the mandate for medical and religious objections, if the employer institutes reasonable accommodations wherever possible, and if the employer does not apply its policy both pre and post vaccination in a manner that discriminates against employees because of religion or medical situation. Now, the important takeaway to all of that is there are probably better options for approaching vaccinations than doing mandates. And that's the stuff that my friend Ken is going to talk to you about. And with that, I will turn it over to him. And I wish him all the luck and that his slide thing works better than mine did.
We will try, Bob. Hi, folks. My name is Ken Bartholomew. I'm with Rath, Young & Pignatelli, a law firm here in Concord. And I'm going to try to share my screen. Can you see the PowerPoint there?
Yep, looks great. Just click on presenter mode if you don't mind on the bottom right.
Bottom right.
Down. To the right a little bit.
This one here?
Nope, to the left. That one right there. Yeah, click on that. That should bring up your slideshow.
There we go. Great. So I'm going to deal with some of the other issues that are related to vaccination policies for employers. Things to keep in mind. None of these things are really mandatory or not mandatory. Like Bob had said, a lot of the issues are matters of degrees and matters of risk, as I would say. But for example, pre-screening questions. If your organization is either asked to collect employee information about vaccinations or to actually prepare to distribute them internally at your company, you need to be careful about these pre-screening questions. They definitely would elicit disability information, such as comorbidities that increase risk for those vaccinated. And you can avoid those by, for example, using a third-party vendor or getting the vaccinations from a public provider. Or if you are going to collect information internally, use the same folks at your organization that already are dealing with collecting disability information, which are those who would engage in this discussion with folks, employees who have ADA issues. So the reason for that is that the HR, for example, the folks in HR should already have access to sensitive personal health information and also have the training policies and systems in place to keep that information confidential. Vaccine incentive programs must be careful. These can create ADA and other issues. As Bob had mentioned, there are religious exemptions or religious reasons for not getting vaccinated, then there are medical reasons. Those groups of people, those who have religious reasons for not being vaccinated and those who have medical reasons, both fall under protected classes. So creating an incentive program really needs to be carefully tailored with Labor and Employment Council, I would argue. And that's because if you provide differential incentives to those getting a vaccine compared with those who can't get a vaccine for religious or disability reasons, that can expose you to anti-bias laws. And they can also be unlawfully coercive or create wage and hour concerns depending on how those incentive programs are structured. So you just need to be cautious about it and talk to someone who will think about these issues and are familiar with these issues from a labor and employment law standpoint. Not that it's not being done. I've already seen, I think it was Bangor Savings Bank is doing a $500 incentive for their employees. There are also OSHA compliance issues that you need to be aware of during the midst of a vaccination program. OSHA requires employers to provide a safe working environment for its employees. COVID-19 protocols are part of that through the guidelines issued by OSHA last year, such as distancing and masking and hygiene stations, et cetera. Those should continue after vaccinations. And the reason is, as we know, Much remains unknown about potential COVID transmission by vaccinated workers, although that's changing already. And also unvaccinated employees that are most at risk may also have ADA protections, and you wouldn't want to skimp on the protocols that are currently in place once most but not all of your employees are vaccinated, and those who aren't are part of a protected class. Just want to share, you probably know this, but the most recent CDC guidance says that post-exposure quarantine and testing requirements have been eliminated for most asymptomatic and vaccinated workers, not healthcare personnel. So healthcare personnel with immunocompromised conditions should consider continued work restrictions, and fully vaccinated inpatients and residents in healthcare settings should continue to quarantine after prolonged close contact with confirmed COVID cases. But as you all know, this changes frequently. This was just from 20 days ago, this change. So monitor OSHA and CDC guidance for changes. This sort of tails along with the end of Bob's discussion. From what I've heard and what I've recommended is that either instead of or prior to implementing any mandatory vaccination policy, an employer should probably develop a comprehensive outreach and education system first. The guidance with regard to having a successful outreach like that is to try to utilize employees who are already involved in that role in an organization. So already involved in outreach and education. For example, school nurses in the educational setting, members of a wellness committees, for example, at my law firm, would be a great example of those who are already used to and who employees are already used to hearing from with regard to health-related matters. And it's also important to recognize that any education should obviously not just include the safety and effectiveness of vaccines, but the need for continued vigilance during the two-week post-vaccination period, post-second shot, if you have one of those vaccines. There are also issues with regard to discrimination post-vaccination. This is a matter of risk, not a mandatory thought on my part, but employers should generally not treat vaccinated and unvaccinated workers differently unless there's a really good reason to do so that can be justified. For example, if you segregate vaccinated and unvaccinated workers into different shifts or teams, you say that unvaccinated workers can only work the night shift, for example, because that class of people will necessarily include those with religious objections to the vaccine or ADA exceptions to get from getting vaccinated. That could be considered adverse employment action that creates essentially separate and unequal groups or assignments for those protected classes. And I think this sort of goes without saying, but I think it's important to say it anyway. You should not be, as an employer, identifying vaccinated and unvaccinated workers, like making vaccinated or unvaccinated workers wear badges, or be confined to a separate office space, or having lists of vaccinated versus unvaccinated workers. That goes along with not keeping important protected information private as an employer. So that is my presentation, and I know that Jim wanted to leave some time for any questions that people have.
Bob and Ken, thank you very much. Very much appreciated. I'd also like to bring on our panelists. Lucy Hodder, good morning, Lucy. I guess it's a good afternoon now, Lucy. So I wanted to kick this discussion off. I know, Lucy, you've had some discussions with the AG's office, and I wanted to learn a little bit more on what was the tenor of that discussion.
Well, thank you, Jim. And more importantly, I thought the information provided by Bob and Ken was excellent. And I had some questions, if I could start with that, because there's been so much conflicting guidance as the vaccine has rolled out, and obviously we need to take in consideration where we are with the access to the vaccine, as the employers, especially healthcare employers, are considering what to do. We do know that amongst our healthcare entities, we're not getting 100% vaccine by any means. So there's still a hesitancy, anywhere between 60 and maybe 80% amongst healthcare employers around vaccination, which may change over time. But I was concerned and wonder what you thought. In the EEOC guidance, it talks about employers should conduct an assessment to determine whether a direct threat exists that would support their ability to both require a vaccine and keep people who are not vaccinated, accommodate them in a way that maybe keeps them away from patients. And they say in that guidance that a conclusion that there is a direct threat would include a determination that an unvaccinated individual will expose others to the virus at the work site. And that's a really broad statement, right? So that direct threat could exist anywhere, everywhere, that someone who isn't vaccinated could expose other employees, or for healthcare employers, patients, to a direct threat of infection. So how does an employer manage that when they're in the healthcare field and patients are coming in for care to that setting? How are they supposed to acknowledge or minimize or address that direct threat that could exist when employees have direct patient contact and are not vaccinated?
A great question, Lucy, and I'm sure Ken will weigh in on it as well. When you look at the EEOC guidance, and that's kind of what makes it that sticky quagmire that Jim talked about. We have what they put on paper, and it's not enough. It's not enough of an explanation. So, we as lawyers, we approach this and we say, well, let's look at the totality of the circumstances. Let's put all the pieces together and say, okay, what does this person do, and what's their exposure, and what's that imminent threat? What does that mean? Can we find some way to articulate that in a consistent way that we can carry forward into a policy and make use of it? Outside of healthcare, in retail and some of those other areas, it may be a lot harder to find that there's a direct and imminent threat to persons because, for example, my son's been working at the Shaw's grocery store all the way through COVID as a cashier behind the plexiglass. Could you now say after 388 days of that if he's not vaccinated right this minute, it's an imminent and direct threat to somebody? Well, I think that would be a tough argument. In the healthcare world, a lot different. There's a lot more very close contact with patients in the healthcare world for lengthy periods of time. We also have some data that shows that the transmission of COVID in healthcare settings is a lot higher than some of the other settings that we look around, especially in long-term care. And so there's much more support for the idea that in the healthcare world, you probably do need to make sure that everybody's vaccinated, if possible, with exceptions for the religion and medical reasons. And if not, what are the other PPE that I could start to use to protect from transmission, whether that's N95s or on down the list of plexiglass barriers and gloves and masks and sanitation and ionization in the air units and all of the kinds of things that would try to help that. And really think about it from what would I do at the end? If someone was saying you did it wrong, how would I defend what I did? And say, well, I sat down and I considered all of these factors and I made these changes and I did these things and these are the people that were vaccinated and these were the ones that weren't, and here's how. And does it pass the test that we would all put to it to say, well, what do I think of that? Is that a reasonable approach? Did someone do this correctly?
So I'd take this a little bit more detail would be required. So in terms of a healthcare setting, I'd say it depends really on the kind of healthcare setting. Bob had mentioned long-term care facilities, and we know the risks that go along with workers in long-term care facilities and residents, and the prevalence of infection and the risk when someone does get infected in a closed community like that. And that happens even with diligent COVID protocols in place. On the other hand, in a place like, say, an ambulatory surgery center, where you might have a policy for patients that requires pre-testing before surgery, and you have PPE in place, you can imagine that if you said, oh, you have to get vaccinated to work here, the response would be, wait, are you saying that all this time before the vaccine was unavailable, that we were putting patients at risk, right? So you don't want to be put in that position. So it really, I think, depends on the type of healthcare services you're providing. And in a hospital, you have mixed services, so it really depends on the area of the hospital and the services that are being provided. You're going to have maybe more of a risk in a cancer center where you have immunocompromised people having cancer treatments versus, say, an orthopedic OR area. So I think you need to take those into account and then justify a policy if it needs to be in place. I'd say, again, as I said in my slides, the first step should be outreach and education. And only if you can't manage to get a majority of folks vaccinated through that outreach and education, and then you take a look at those who aren't getting vaccinated, are they limited to just those religious objections and medical exceptions, ADA qualified medical exceptions, so you know whether you're dealing with a protected class or not when you're treating those employees in a different manner. And these are tough questions, and really it's a matter of how much risk you're willing to put up with, because you accept risk on the other side as well. When patients contract COVID, it can be very difficult to prove that, but the allegation can certainly be made. And if you don't have a strong policy in place that is intended to protect those patients, both with pre-screening, pre-testing, COVID protocols in place, and then also then a post-vaccination policy, you're increasing your level of risk from a malpractice standpoint.
Great. Lucy, did you have another question?
Well, no, Ken, that was so well said, because that it is that countervailing risk that especially the healthcare employers have around what if someone contracts the virus or claims they contracted the virus. Do you feel that customers and or patients will be asking for or have a right to the policies around vaccination, testing, or safe workplace?
So I think it's important for healthcare providers to be open and honest with their patients with regard to all their COVID protocols. And vaccination protocols are part of that safety protocol. So it needs to you need to take those patient safety protocols that you are hopefully letting your patients know about, and I'll get back to that in a second, and also now incorporate your vaccination policies that's been spoken to with counsel and vetted for risk, and then you make a risk assessment decision, and then you make that available to the public as part of, not separate from, but part of your COVID safety policies. And the reason for that, which is what I'm going back to, is you want to make sure that you are encouraging your patients to seek regular care, because when you don't explain to your patients why it's safe to come into your healthcare setting, you're putting those patients at risk in another way.
Okay. Let me pivot, if I could, and talk about another audience in this context, because you mentioned testing. So most colleges and private high schools have mandatory testing policies for everyone, at least randomly or on a periodic basis. So how does vaccinations, can colleges say that if you want to come back to campus on the fall, that you're going to have to prove that you have a vaccination? And what are the potential risks there?
It's a very interesting question, and most of my work is with healthcare and private employers, so I haven't had to answer the question with respect to colleges. I have a little bit with respect to public schools, where we do have other vaccination requirements, and you can't attend, elementary school or high school, and even colleges have vaccination requirements already for other things. I would approach it the same way with respect to the exceptions. You've obviously got to honor the religious and the medical exceptions to it and figure out what that means for how you're going to manage your campus. I don't know if I would necessarily advocate for it, because I think that you'd have a challenge with making that argument that it's the functional equivalent, the educational equivalent of job related and essential to what you have going on in a school. In addition, especially for the elementary and other private primary schools, vaccines aren't going to be available for under 16-year-olds for a while. And you certainly can't have a mandated policy for folks that don't have access to it.
Yeah, I think that's right. And I'll tell you, I'm also a school board member in my evenings. And one of the things that I'm really hoping for is that the emergency authorization is converted to a regular authorization by the time next school year rolls around, because it just makes it that much less risky from a legal standpoint to have a mandatory vaccination policy for coming back to, say, a university than not if you have only the emergency authorization to work on.
Right, and I would just add to that, the risk there, the countervailing risks, I agree with everything that you both have said, is you also have teachers exposed to the students. So there's another group that you're responsible for as a university or school that includes the teachers, right? So you got to make sure they're in a safe workplace as they come and teach the students. And then you also have, as we've seen throughout the last year, you have the communities, which are the hosts of these sort of mini towns, which are our colleges and universities, and just an incredible job across New Hampshire for repeat testing. So I think what we're going to see is sort of an adjustment of, we've had, twice a week testing and very strict protocols and disciplinary procedures. In the colleges and universities, we've had, remote and hybrid in the elementary and high school settings. What does that mean during, the post-vaccination time period? We don't know how long it's going to take to ensure that there's a safe vaccine for kids. I'm sure it's going to be much more complicated when you have parental consent required for those around the vaccine. And I think it's going to be really complicated. So schools are going to have to continue to have all of the safety measures in place in lieu of the vaccine to help that against that protection.
That's great. That's a great answer. I have another question here from a participant. It says, what is the appropriate approach for an office, possibly a law office, which sees clients but has been remote, to go back to work when a person declines immunization and all others are vaccinated? Would all the staff need to be masked and 6 feet apart due to that one person? Is it discrimination to require that one person to wear a mask or sit 6 feet apart? Second question. What are the rights of the other employees and clients not to be exposed, especially when there are variants exist? And I guess what's the most important question there? What's the prevailing question there?
So it's a matter of risk again, and the least risky thing to do, in my opinion, would be to maintain your COVID protocols in place. So don't have one person wear the mask. Have everybody wear the mask, even if they're vaccinated. Have social distancing maintained, at least until community spread is much, much, much lower than it is. And we have a understanding of both the variants that are out there, which we don't really have yet because of lack of sequencing, widely used in the United States. And also, we have an understanding of, the risk of transmission through vaccinated individuals. So I think it's important to maintain those protocols. I don't think it has to be done to the extent that you must all be remote and you must exclude clients from your law offices. But, as the CDC guidance says, you should not have large gatherings yet. You should not have, large unmasked gatherings. We wouldn't do like hors d'oeuvres in our boardroom, for example. It's just, we're not there yet. And even when it looks like we might be there, you probably wouldn't want to err on the side of caution. I don't think it's discriminatory to say you have to maintain your COVID protocols, especially if you don't identify that you have to do it just if you're unvaccinated.
I agree with that. And I think that one of the advantages for the law office that was given the example is an easy one for me to think about because here I am. We are very, very good at working remotely. We can do almost seamless work remotely and meeting with clients and things. And we can do it frequently. We've done it during COVID. We've done it during people's quarantines and things. And so as you go forward and you keep that option available to your employees, it won't even single somebody out or call attention to somebody based on their vaccination status, because all of us have days where we're here, there, or elsewhere. And the new tools that we've learned have really helped us do that. And I think another justification for Ken's statement about maintaining your COVID protocols is, regardless of what one or more of your employees would do, your clients are going to be all over the place with whatever they choose to do. And they're going to come into your place and they're going to be exposed to whatever is there and change the exposure of whatever's there. And you'll never get a grip on that. You'll never be able to control it. I have had a few of my clients ask me, can I require all my patients to get vaccinated, or can I require all my customers to get vaccinated? I don't think there's legal support for that anywhere, for closing your business down and saying, I'll only do business with you if you're vaccinated. And so you're always going to have to deal with the idea that the public that you deal with could be anywhere on that spectrum.
It definitely
So,
raises, sorry, Lucy. I was just going to say, it definitely raises the specter of religious discrimination and disability discrimination if you just categorically say, we won't serve unvaccinated people.
right. And you all are the ones in the trenches with these employers. So I get to raise these sort of far out issues, but I do think that there's going to have to be more guidance, and everyone's going to have to follow very closely with some of what the large employers do to see what's created as a little bit of a norm once vaccination is very accessible to all age groups, and the vaccines are no longer emergency use, because one could certainly see that, again, if vaccinations are accessible, if you had a policy that said, if clients are going to want an in-person meeting, we suggest that they be vaccinated before doing so and can accommodate them fully remotely in the alternative. I mean, I can see that could be a wave of the future as things progress. So there's all kinds of reasons to be very careful about discrimination and making sure there's reasonable accommodation. At the same time, I can see why employers are really concerned about making sure they're taking the best safety precautions, which may include ensuring as many people as possible who are involved with their employees are protected as possible.
I'm starting to see some of those post-vaccination policies start to crop up in, for example, the guidelines that cruise lines are putting forth for cruising, even though it's not permitted from the United States yet. They're setting up in the Bahamas and they're starting their cruises from the Bahamas. And what they're requiring, at least they're not doing it yet, but they're saying that they're going to be requiring either proof of vaccination or strict testing protocol. So you have the option of not being vaccinated, but then you have to go through the strict testing protocol. Is that discriminatory for someone who can't get vaccinated for medical reasons? Probably not, because you still have another option. You have what we would call in the law a reasonable accommodation, even though it's for guests as opposed to employees. I think it would still apply there.
Mm-hmm. And I thought, Ken, your advice about setting up using your safety committee, and maybe even expanding your safety committee. And most employers obviously have done that during COVID to try and figure out, virtual participation, et cetera. And really using that committee to troubleshoot and air the situation is obviously going to be a critical component.
Well, everyone, thank you very much. So kind of final last words, any final thoughts before we go? We're kind of coming up on the hour.
I'll give my final thought, which is, as from the beginning of this pandemic, everything we told you now could be different in a week. Things change so quickly. The guidance changes so quickly. And frankly, it's hard to keep a handle on it all from both a healthcare perspective, recommendation, and a legal recommendation perspective. So, just you got to keep your eye on the guidance and see how things are changing.
I'd echo that and say not only could it change, it most certainly will. And it echoes, I think, what Lucy picked up on from Ken is that a safety committee or some proactive approach to, as an employer, saying every period, month or 2 months or quarter or something, let's open the hood and look at this. How are we doing? Should we make any changes? What's new? What have we learned? And decide whether, continuing these things into the future makes sense. Policies that we develop for 5 years down the road are going to look a lot different than the ones that we develop today. And it just takes that kind of dynamic, nimble approach to it. We've learned so much in a year. I mean, remember a year ago, people washing their groceries when they brought them home and, those kinds of things because of the way we thought that COVID spread. And we've learned so much more in a year, and we're going to continue to learn at that rate. And that's going to always make this a moving target.
Lucy, I'll give you the last word. You have
what they said. Excellent. They provided excellent advice, and I think we should listen to them early and often.
Thank you for that.
Thank you all very much for participating in this week's Alliance call, and thank you for all the valuable information. We will make the slide decks and this conversation available this afternoon on the Medical Society's website. So Bob, Ken, and Lucy, thank you very much for your time and your knowledge on this important issue impacting New Hampshire businesses and other entities. So thank you again. We'll conclude our session this week and look forward to seeing you all next week, same time, same station. Take care all.
Thank you, Jim.